Welcome everyone to Geriatric Medicine Grand Rounds. Our presenter today is one of our four geriatric medicine fellows who each get to choose whichever topic they'd like for Geriatric Medicine Grand Rounds. And you can go ahead and take it away, Clara.
Good morning, everyone. Thanks, Kate. Yeah, so as Kate said, I'm Clara. I'm one of the Jerry Fellows, and today I'm going to be talking about like some cultural understanding of dementia in Chinese American communities. Obviously, I'm a little biased, but actually, so I decided to choose this topic actually because I did my residency training in Long Island and actually had very little exposure to Asian patients there. I believe I saw like maybe two or three my entire time there. So coming here was kind of like really cool to see such diversity here and to have that exposure. But I found myself actually wondering, kind of I didn't really understand the nuances of how to work with these patients, which is kind of what got me interested in looking into this topic. And then also kind of found out a lot of really cool things in preparing this topic for everyone. So please feel free to join in with any questions or with any insights or thoughts. Also, I'm always happy and eager to learn more. So yeah, without further ado, let's keep going. Uh-oh. Let's go to the next slide. Thank you, computer. So we're just going to go over a quick intro and a case. And this is kind of the outline that's going to happen. We're going to talk about language things, misconceptions within the community. And we're just going to also talk about like key components in assessing dementia, and then also other cultural perspectives, caregiver challenges, and then also kind of look into challenges in the research realm for this. So kind of going back to, oops, sorry. There's lots of little bars all over the place. But basically, once again, kind of giving even more credence to why I'm giving this talk. Asian Americans are actually the fastest growing major racial and ethnic group in the US, including in the older adult population. It's actually over doubled in 20 years, between 2000 and 2019. And even a couple of years ago, there's almost like 25 million Asians who live in the US now, which is over 7% of the population. And in these same research, they also found that 22%, almost a quarter of that population specifically, is 65 and older. So this is obviously very relevant for us in the patients that we see. And then also, I decided to focus on the Chinese population. Obviously, I have a slight bias, but also it is what accounts for one of the biggest groups within this population of Asians. That does incorporate a whole lot of people. So I do hope that in the future there could be other topics on all these other subgroups, because it's very important that we don't just conglomerate everyone into Asian Americans and think of it that way. I think each individual subgroup has very important cultural considerations that need to be specifically understood for each population. And then, so for this case, it's a 91-year-old. I'll just talk through it really quickly. It's a lot of text, apologies, but basically, it's a 91-year-old male. He's Toisanese speaking, which I'll talk about as a subset. He has history of moderate dementia and other like CAD, CKD, all the classic things. Unfortunately, he was accompanied by his wife and son to the visit. Unfortunately, they declined an interpreter, so most of the history was actually obtained from the son, just because they said that they had difficulty in the past getting interpreters in Toisanese. And the visit was to establish care, and so it's getting to know this patient for the first time. And so he had a history of dementia. I did see that there's no cognitive testing on file, but he did need help with some ADLs and a lot of his IADLs as well. It was interesting because the patient was pretty quiet most of the visit. He had really bad hearing problems, and he was supposed to get hearing aids, but his son said we talked to him a bunch about getting it, but he's not interested. He's old, so he won't be able to hear, remember anything, so there's no point in trying anymore. We had like this full visit and discussion, and so we kind of did the normal, intake things. And at the end of the visit, I offered a cultural mediator to help with coordination of care, but then his son's like, I'm his family, so I could take care of him. And there's just also no pulse or ACP documents. So there's just a lot to kind of wrap up still for that case. But I'm just curious what thoughts are from the audience in terms of maybe some kind of things that you notice that might be particular things that might be specific to this population or some challenges that you might recognize if you were the provider in this situation that you want to kind of address in the future. I'm just curious what thoughts might be. Yeah, I'll go back.
Well, I think this is Isabella. I think that him not wanting a cultural mediator or interpreter can certainly make it hard for you to know what the patient is actually thinking, because I'm sure that, like it's not because the son is a bad person or anything, but he's probably um, filtering things that the dad is saying, right? And then it also makes it harder to do an actual cognitive assessment and to assess his mood, again, because of all the filtering. So that would be
Yeah.
one thing.
Thanks, Isabel. Appreciate it.
Um, I, I think this patient feels really familiar to me, Clara. I was almost like, what? Do I know this person? And I was like, wait, established cat. Nope. Um, but I think there's this almost like this nihilism with geriatric syndromes that I've observed in my Chinese patients, in that, oh, there isn't anything to do about dementia, or there isn't anything to do about falls. So, like, what's the point? So, I think I know I've struggled in the past to really indicate to people that there are reversible things or disease modifiable interventions. So yeah, that part feels like a theme.
Thanks, Ruru, and thanks, Isabella. I'm just going to move forward for the sake of time as well, but then I'm just going to go back to the case at the very end. So just want to just kind of percolate some thoughts a little bit. And so going to go into like more the meat of today is just kind of thinking about kind of major barriers and care considerations that we kind of already briefly talked about in our outline. So one big thing is the language. As I mentioned before, I'm only talking about within the Chinese American population, but there's also even then 7 to 10 major language groups and over 300 unique dialects. And so that's a lot. But there it is often like there are two major ones oftentimes, like Mandarin, so like Putonghua, which is the official language of China. It's the most common dialect used in China as well. And then there's also Cantonese, which is also more common in the southern area, but it's actually a very common language you see here in the Pacific Northwest, Northern California, and the East Coast. The Mandarin is very common in Southern California also. And then there's also, I brought up Toisanese just because that's the third most common, and it was something that my patient spoke as well. So it's something to keep in note that, when you're asking for interpreters, I think everyone probably already does this, but just making sure you specify which specific language, because I saw a lot of papers talking about people asking for, oh, can I have a Chinese interpreter, please? And then somebody who speaks the wrong language comes up. And so just a quick reminder in that standpoint. And then unfortunately, the smaller languages like sometimes Toisanese and a lot of other ones, like there's all Shanghainese, lots of other languages. You can try to bring them up on interpreter. Sometimes it might not be available. Sometimes they either speak Mandarin or Cantonese as a backup, as like if they speak enough of it, it might be manageable to at least communicate. And as Isabella was saying, at least get insight into what the patient's thinking and all those things, rather than just from the family. So it is still ideal to speak with interpreters specifically, but just some considerations. And then also, there's a lot of languages, but it's mostly a shared written language. It's mostly at this point simplified Chinese, which is the characters on the right bottom versus the traditional, which is the right to the top. But then just something to also consider, there is slightly different variations as well, but at least there is one unified written language. And why is this so important? As we know, we already talked about how important the language is to be able to communicate your physician about, your needs and like what your actual insight is. And also, their communication obviously impacts their interpretation of their care and also their interactions in general. And so these are just some surveys that were showing it within some populations and showing kind of how much confidence that puts them into their doctor, and that plays a lot into the patient physician relationship as well, and that's why this is so important. Unfortunately, around 51%, so over a little over half of Chinese immigrants lack English proficiency, and there's obviously a huge dearth of healthcare interpreters. Nationally in 2022, there's only 205 for the entire nation, so that is not quite enough. And then we're lucky that at Harborview we do have wonderful interpreters, even though there's no Chinese cultural mediators. So as Kate keeps telling me, just put in those referrals to cultural mediators for Chinese if needed to just encourage, unfortunately, there's not one currently, but we still have the wonderful resources. Thank you, Rima, for resharing these slides with these with me very recently. This was stolen from one of the ethnomeds things in October, but just as another reminder in terms of phone numbers. I didn't realize that they're actually on the doorway in our Harborview clinics. So in terms of the phone numbers that we can give to patients in our after visit summary, because that side of communication is really important too. I think I've been guilty of that, where I give them patients after visit summaries with just our clinic number, but it's more important to give them the interpreter number so that they can be led to the clinic afterwards. And then at the Ethnomed, they also reminded us of translated documents that we're not supposed to use Google Translate officially. So I think I've sent translation requests a couple times and it comes back within a week, and then we end up mailing to the patient. So these are just important ways to make sure our patients feel like they have autonomy and ownership and are able to communicate with us in an appropriate manner, like our English speaking patients. So of course that's one barrier. Another one I want to talk about within our Chinese population is, okay, this was a strong, I just said like the understanding of dementia within this population. So it's interesting because more than half of Asian Americans feel like, memory loss is just a normal part of aging. And so it just shows kind of how much education is still needed within this group to show that, dementia and mild MCI, it's not normal. And so just to come in to see their doctor, just to get worked up and just to see what resources and that they could be connected with. And then so there's a interesting paper that showed that 13.8 older, this is conglomerating to Asian Americans, but they incurred increase in confusion memory loss, but most of them didn't report symptoms of dementia to medical professionals because they thought it was part of normal aging. And then another Alzheimer's Association thing showed that only 18% of patients in Asian Americans are aware of mild cognitive impairment. So once again, there's that lack of information on that standpoint. And one potential underlying thing that could be underlying this lack of information is the stigma attached to the actual word dementia. It's really interesting because the Chinese word for dementia actually literally translates into like crazy catatonic, which is obviously a very stigmatizing word and something that people don't want to have. So unfortunately, there's been a push to have a new word used for the word dementia. So there's ones like loss of wisdom, or the more scientific way of saying it, degenerative brain disorder. So that can be something you want to maybe consider asking your interpreter, like before the visit, being like, oh, I just was curious to see, like, like if somebody's having a pre-visit discussion when possible with interpreters would be helpful, just to kind of like talk about, especially if you're going to do a cognitive eval, just talk about what you want to discuss, but also you can maybe gently bring in like, oh, just curious how we should talk about dementia, and just want to make sure it's like as like less like least stigmatizing as possible. And then so because of the stigma, there seems to be like a connection that actually dementia is like the patient's fault. It's like a mental illness. It's caused by too much worrying. It's like bad karma, bad jujus. So then that just feels more very like pointed towards the patient and feels a lot of patient blame, and contributes to that stigma as well. And just as a side note, there's also a similar stigma against palliative care and hospice, where it sounds like do nothing care or last minute care, which once again are also being there is a movement towards having more appropriate or kinder words for more representative phrases for those. So just also something to note as well in terms of why there might be some stigma against these conversations. And then also in terms of there's our left side is all kind of Alzheimer's Association statistics in terms of, even though there is, lack of information, there's obviously a lot of concerns about it, but also that this population feels like they have barriers to getting like, care for it. So a lot of them say that they don't know what kind of help to seek, or they have difficulty accessing medical resources, specifically information about the risks and benefits of risk of treatment, risks and options for treatment for the disease. So that's re-emphasizing how important it is for us to educate our patients on this information. And then some, I think there's one study I was looking at that was looking at like kind of surveying patients and their children and seeing what type of information they're really specifically interested in. And they just didn't know what a memory doctor was. So they did prefer the PCP because of trust. They didn't know when they should get a cognitive eval. So just, earlier is better and just counseling on that. And they didn't know what would happen at a visit when they should repeated myself. And they didn't know how to have those difficult conversations. So, it's reassuring that patients and their adult children are curious about this. They're interested in it. Hopefully, it's becoming less stigmatized. But this is all why this is also so important to understand that context. And lastly, there was a study that was looking at Asian Medicare beneficiaries in California. And once again, sorry, hitting nail on hammer, anyways. But basically, they were saying how, unfortunately, in the Asian population, they were much less likely to receive a timely diagnosis of Alzheimer's disease and related dementias. So there's only 12% of beneficiaries were diagnosed at the first stage of MCI versus 23% in non-Hispanic whites. So that is almost half, which is huge. And then similarly, it's like only a fifth of patients who were of the Asian beneficiaries got kind of what they consider full diagnostic evaluation compared to non-Hispanic white. To be fair, the full diagnostic evaluation they commented on was kind of, there's three components, which was referral to like a memory care doc, like a specialist, lab assessment, and then imaging. And so I think we don't necessarily do all three of those necessary for every patient, but I think just the comparison in the management, this is just comparative. And so I think that's still striking as well in terms of how the beneficiaries are managed differently. Last one is also similarly how in Asians and whites there is also a difference in, sorry, I should have circled it. There's like the fourth or fifth last line that says incident MCI diagnosis. And it shows that Asian numbers had Asian patients in this study had only 12% were diagnosed at MCI level versus 23% of whites, which show that these patients who are coming in concerned for memory, they were diagnosed later stages dementia compared to the Caucasian population who were caught earlier at the MCI stage. And then, of course, we should do our part in educating our patients. There is also, of course, information online that has lots of educational materials to provide information about dementia to Asian patients. When I was going through them, unfortunately, there are a lot of broken links or ones that kind of, when you click on a link, like I did go to the Alzheimer's Association, like the Asian website, the Chinese one specifically, and it did have good information. There were a lot of broken links, so that would either go back to English speaking sites or written sites, or there were some broken ones too. And then the really cool like features are on English speaking sites like the Alzheimer's Navigator and like information on how to get a cog eval. Those were only in English, spoken in English. So that was something just to keep in mind, just because I think a lot of times we do refer to Alzheimer's Association, and just something to note. There's a lot of other good information. A lot of them do have a lot of text, which is a little overwhelming, but just keep in mind that to maybe look into the educational materials before sending your patients there, just to maybe have it a little tailored or make sure it's patient friendly for our patients. Okay, so that was a lot about those two topics. I just want to pause to make sure if there's any questions about anything I said, because that's already a lot, but I just wanted to check. Okay, and then so I'll just move on. And then there's a little bit, I'll just talk about the workup in terms of the cognitive, actually, I didn't look at the chat. I think there's some, these are old, right? Okay, sorry, thanks. Uh, in terms of evaluation, I think in terms of cognitive evaluation, I know a lot of us do MOCAs, and that's all appropriate. And I think a lot of us do this already. Like I know we do a harbor view, but for our patients who speak different languages, it's also important to actually use a different cognitive testing called the RUDAS, the Roland University Universal Dementia Assessment Scale. It's more helpful because it's been like verified in lots of different patients with different social cultural backgrounds, and it's also translated to many languages, which is helpful. And it's kind of more on like objective data, like praxis and body information, like less like English skill based information, and like more practical information in terms of, oh, what do you do if you cross the street? Or there's like assessing for safety and like ability to reason through things. It does have still a pretty decent specificity and sensitivity for dementia detection of 82 and 83%, even with like low or no, like there's low or no influence of educational level, which is also very helpful and very important. Sorry, this is stuck now, but that's okay, because I was just trying to show you. I think a lot of people have done the RUDAS. I was going to split this up the slides to make it easier to see. It's a little small still, but it's kind of I think it's just the things I mentioned in terms of it shows memory, visual spatial, praxis, visual constructual, drawing, judgment, and then language is like more like easy stuff, like just you name as many animals as you can, not us telling you, oh, this is a rhino, do you know this like, or this is a bear, do you know this animal that doesn't exist, that you don't see as much in your country. So yeah. um and then, so like as I mentioned, there are other forms of evaluation as well. The MSE, which we don't use as much anymore. It's not as sensitive. The MoCA, we use a lot, but there is like racial and cultural bias, and then cutoffs can vary widely. It has more pronounced educational effects also. So just things to keep in mind with the MoCA. There's also a test I didn't really know as much about either, called a CASI, which is a 25 item scale also, and it's only for a couple dialects or languages, Japanese, English, and Chinese. But it's also maybe not quite as recommended, just because also it does have more of an influence, education has more of an influence on this test. So I would probably go more towards the RUDIS as well, even though there is this nice other option that seems to maybe be a little bit higher like specificity, I believe. But then, yeah, just something to keep in mind as well. And yeah, kind of like what I said before, the MoCA has good specificity in general, but poor sensitivity in detecting dementia in older Chinese Americans specifically, as seen in this study as well. So not the one that we want to use for our patients, for the Chinese American patients, sorry. Okay. So I think the next section will probably be the biggest section I'm going to talk about. It's just going to kind of go into some cultural background and consideration of things, just to kind of better understand our patients, some of our patients who might be sitting in front of us. And so before I get into this, there's a slide I took out from that I had up earlier, just talking about actually, just basically talking about that there might be different levels of kind of some patients might be more traditional, some might be less. I think I do get into it at the end of these slides, but I just want to let you know that also when I say the Chinese American population, it does include both immigrants and US born uh, um, Chinese Americans. And I had a nice graph. I have it at the end if anyone's interested, but there has been a decrease in the amount of proportion of that's immigrants compared to US born. I think the Chinese one was from the 70s or 60s and went down a little bit. And so that's just something to know, is that, the patient in front of you might be more traditional, might not be, but these are just some traditional values I just want to share and explore. So in terms of these traditional values, a big one is filial piety. And so it's born from Confucianism. It's really about the connection between like a sense of your responsibility to your elders and respect and all these things. And so for that reason, oftentimes children can become caretakers for the older adult. And also, the children often feel, or family members can feel a sense of responsibility and protection of these patients. And so just saying some things that, you want to keep in mind when taking care of these patients is also ask if they want to include certain family members in discussion, maybe these children or other family members who are really important to them or who may be in charge of their care. Something also to note though is like, there's pros and cons, but also sometimes the family may want to quote unquote like protect the patient as part of the responsibility to them. So that can include things like, oh, maybe you don't want to give the full prognostic detail to the patient, or especially if it's like with this new serious illness diagnosis or something like that, or if they don't want to they decline like if they don't want to discuss more in depth in terms of or if the patient doesn't want to discuss more in depth like healthcare proxy because like, oh, my children will do it. So those are things to consider in that, in patients who kind of really strongly adhere to these values, that certain conversations might be more important in those situations. And so I think it's really important to include the family in decision-making process, and also, once again, to educate in terms of, for example, like the importance of having the discussions with your children, and but also maybe if they're saying resistant to having sharing all information with the patient, just giving that education on how, well, first of all, it's patient's information, but also B, just kind of to educate on the importance of you know kind of working together to provide the right information to the patient. Just also just definitely working with that family context. The other thing is also kind of more emotional harmony is also a big concept, and so it's kind of sometimes it can also be a little avoidant as well, similar to so things like family patients might try to want to avoid being a burden, or so they're like, oh, I don't want to bring things up because I just want things to just figure themselves out. Or it can also kind of depict itself as, oh, I want my family to make the decisions all together because I just want everything to them to all get along together also. Or it could be things about avoiding talking about bad things or serious illnesses also, so that it can also be a little superstitious in that way, where the patients want to avoid talking about bad things because they don't want to say, oh, I'm going to bring it on by talking about it. So those are things to also keep in mind if patients seem a little bit hesitant to discuss things as well. And so maybe it might be helpful to be a little bit more indirect when bringing up the topic, at least, just to kind of give them a little bit of an in, so they don't kind of push back automatically. And so you can give example of other people's serious illnesses and ask them what their opinion is on about it, or you can get and see what their perspective is on that other case, or you can use like more positive words to describe, like instead of dementia, use like, can we talk about brain health or things like that, just to get an introduction into the topic, and then you could see how it plays out from there as you continue to develop trust and relationship with the patient and their family. I think Ruber brought this up, but also there's like this fatalism a little bit where like kind of serious illnesses and things are unpredictable, not controlled, and they're just destiny. So there's like a saying where you're born, you age, you become ill, and you die. So just things will just happen. And so sometimes for those, it can be a little challenging to address as well. But I think having encouraging patients to have like open-ended questions and just continuing that counseling about, oh no, um like if we address XYZ earlier, then it doesn't have to end up down that road and stuff. So I think just kind of address I think the rapport and trust is very important in these situations, but I think having just dialogue about it is kind of just the important thing as well. And then something else to note is that also sometimes doctors can be viewed as very trustworthy authority figures. So just the things that you say will have a lot of weight a lot of times, but at the same time, on the opposite side of that, sometimes patients want to do something called like saving face. There's also a term for that too. And so they might not verbalize all their concerns regarding the medical care because they don't want to look like they want to be respectful to the doctor, like, oh yes, what they're saying is right. They might not agree with it, and so when they go home, they might not do it. Or if they have a concern about it, they're like, oh, I must be the one who's wrong. They must, like, I don't know what they're talking about, but it must make sense. And so sometimes that could look like poor medical adherence. And so that's something to keep in mind. Um, the doctor as a trustworthy authority figure might also like complicate like goals of care and like DPOA discussions, because they might be like, oh, you can make the decisions for me. Like, it's not my children, it's you. So that's also something, that's why also it's important to have those discussions to make sure that is not their perspective, and that you kind of, once again, gently re-educate and kind of have that conversation to make a more appropriate family member to make their decisions for them. And so like the approach here would be to, for the, once again, counsel regarding ACP, DPOA, but then for the first part to make sure they're not just trying to save face in front of you, just ask all questions. But teach back is going to be important here too, to see what is it that you actually did you hear and understand and process what I said, and then encourage them to ask any questions if they didn't understand anything. And don't have it be on them, just have it be, just make sure I was clear about this. Just want to make sure that, you know, if just want to check to see if you have any questions. And you could normalize it too, say, oh, a lot of patients have questions, and so that'd be appropriate. This is not a great slide, but this is, I think, what I was getting at earlier, is that there's like a whole gradient of variety amongst, you know, people are individuals, but also level of like how will the patient from you have very traditional values or less traditional values. And so as time has moved on, we are seeing different waves of our populations. I think we are in the time, like the older Chinese American immigrants came like before the 60s, and they came to help take care of their families and other things. And we are still seeing those patients. And so they might have more traditional values. We have like immigrants, working class, who came after 1965, American, the Chinese Exclusion Act. I just said it wrong, but anyways, they might have still very traditional values, but also started to acclimate. They've been here for a while. They're acclimating as well. And then versus by acculturated professionals, or like the young professionals who might have more be assimilated in like Western like working environments, but then they might still have some traditional values. And then there's like a younger generation as well. So there's just varying levels of intermix of how much they adhere to these values or not, just as context. More things to consider for our patients, of course. There are probably patients who are really believe strongly in traditional Chinese medicine, which is kind of a holistic medicine with the goal to restore like balance of qi, which is a vital energy in the body, and there's different meridians that all interact, and the organs and everything all interact. And so it's always about balance, about yin and yang, cooling things, warming things, all these things. And it's important to know about these just because our patients may or may not be using them anyways without even telling us, because they might feel judgment from more Western doctors about these practices, but they may be seeing their own traditional Chinese medicine doctors, and they might be using home remedies in the community. So these are just things that we should keep in mind. So just, I think what's helpful here is to be very open about it. Like if you're like, oh, absolutely no, try, like, you know, these are dangerous, all the things, and of course that's going to shut things down. But then um I think it's important to be open. So that way, if there's any concerns about medications or anything that they may be doing, it's a dialogue, it's a conversation, and it's helpful to encourage routine follow-up, because sometimes some patients might not be interested in coming in unless it's like a last resort if they're like actually sick, and that might be more culturally we're like, oh, I stay home and take my Chinese medicines, but I only come to the doctor's office. Is there something that's not being addressed anymore? But having more routine follow-ups even outside those periods will just help you check in, but also develop that rapport and trust as well. And so some things to note about Chinese medicines is that Western medicine can be considered hot. And so that's why sometimes some patients might not be interested in taking too many of the medications, because it might build up and disrupt this equilibrium as well. I didn't realize that color of the medication can also maybe impact the hot cold level of the medications. And some patients want to avoid certain cold therapies, and also they might want to avoid like cheap generic brands if there are certain medications, because they want to feel like they're being treated for as best as anyone else could be. And so just once again, counseling on that stuff is also very important. In terms of traditional Chinese medicine, it's also important to ask them about what herbal supplements they might have at home. Sometimes they can go to a local traditional Chinese medicine doctor, and they could put together a packet of like 4 to 12 ingredients of things, just all balance of different ingredients. And so there's a lot of different herbs in there. It might not just be one. And sometimes they might not know what's in it either, but it's just important to know A, if they're taking it, and B, if they happen to know what's in it, to know what's there. Some of these medications can have contaminants or heavy metals, and of course, there's those drug-drug interactions. One that's for me, like I was like, oh, ginseng is a very common tea, but the extracts can also decrease the efficacy of warfarin. So I was like, oh, that's really interesting for me. That's something I can remember, hopefully. But then Ethnomed has a good PDF guide about some like a number of major interactions. The NCCIH, the National Institute of Complementary and Integrative Health, they also have interaction, like kind of information on their website. But then there's also an interaction checker. I forgot to post a picture of it here, but it's called Natural Medicines, and then you can actually put in the different like the drugs or herbs, like Western medicines and whatever herbal thing that they're using. You could actually check those directly as well. That might be a resource that could be an option too if you find out what medication they're taking. And of course, well, there's also a stigma against mental health concerns and specifically antidepressants, especially for our older patients who might have more severe stages of dementia. It kind of goes along with the crazy feeling and all the things. Sometimes the patients don't express themselves or present until they have a somatization of that's of the and then so if they have certain symptoms, like, oh, I'm so like anxious, and now they're having certain like jitters or other things, that they find acceptable to talk to a doctor about. But then the actual mental health might be a little bit more challenging to discuss. Psychotherapies also would not be received well, since in terms of it feels like uncomfortable and it feels like confrontation. There's a study that was looking at depressive symptoms in the Chinese population, and then I think it was showing that the bottom line, like the little bottom, the lowest row, it talks about antidepressant use, and they're showing that in controls, like the not cognitively impaired, that the antidepressant use is similar across those two populations. But in the cognitively impaired groups, there was actually a much lower use of antidepressants in the Chinese group compared to the Caucasian group, which was really interesting and striking in terms. I feel like the left side of the controls is a little bit too striking, also similarly striking, but at the same time, it was an interesting study to just kind of highlight the thought that maybe with the dementia and further like mental health symptoms, that might be even more stigmatizing as well. And so sometimes I like to think about with the counseling, it might be helpful to use those symptoms. Like also if somebody has like sleep problems or they're not eating and you're like, oh, mirtazapine, or like if you can use some other symptoms or link it to other like health things are important to them, then they might be more willing to consider medications or therapy or counseling. But also using local resources is very helpful. And so there's Asian Counseling Referral Services in International District. And so there's like wonderful therapists. I've had several patients who see therapists there and really find it beneficial. And they see them regularly, and there's familiar Asian faces. And so having that connection would be very helpful to use our local resources here in Seattle as well. And then there's an interesting study about psychotherapies. This is old, but they use an educational like behavioral package where they videotape sessions and include muscular relaxation techniques. And so apparently that was better accepted when it was delivered in this modality. And so that might just speak once again to if you align with the patient and what they prioritize and what they value, that it might help with kind of going finding an approach that would work for the patient. In terms of diet, just you know, when we talk about dementia, we're also talking about diet and exercise, all the things. Something to note is just that traditional Chinese food, it is a lot of fresh food, which is good. It's lots of live seafood, veg fruits, vegetables. Textures are very important. Lots of regional differences. Lots of herbal teas and soups to have more health benefits. I didn't know about food being toxic to those with weakened health, like crab, beef, egg. But that is also something to consider if you're like, oh, what foods should I avoid? And you're like, oh, everything's fine. Like, well, I still avoid these ones. Um, Anyways, but basically starches like rices and noodles are very culturally important. So um, that might not necessarily be the biggest part of our mind diets or whatnot, but when it comes to those, it shouldn't be so much like taking away. It should maybe be more about what can you do to modify those to make them more beneficial. So I think I saw something about like if you refrigerate white rice in the fridge for like 12 to 14 hours after it's cooked, it actually hardens better so that it's like more the way that it's processed makes it higher the glycemic index changes, and so it's more beneficial in that way. And you could reheat it after refrigerating it, but apparently that improves it. Or obviously, it changes like brown rice or adding like beans or other fibers to those ingredients would be helpful. But it would be not a great start to your visit if you say you should not eat any more rice. So that's very culturally important. So just something to make note. And then usually it's the traditional Chinese diet is not so much like, Panda Fresh, where it's like there's not a lot of deep fried cooking and all things. It is mostly fresh vegetables, stir fries, smaller meat portions. Of course, there's not much dairy, so there's more soy milk and tofu. And there's not so many like desserts. It's mostly like fruit is the like the main dessert, unless it's special occasions now. So just some things to consider in terms of when you're counseling on like the mind diet or other things. And then there's also a Chinese mind diet. So um, there's just like some small replacements. And so like, for example, some whole grains, once again, it is still their staple food, but then maybe just some modifications you can mention. In terms of there's still the same fresh vegetables. There is more, they just switch out the things that they don't use so much. So instead of berries, it's other fresh fruit. And then instead of vegetable, like I think I forgot. I saw somewhere where it said mushroom and algae replace something else. I forgot what it was. And then instead of olive oil, it's cooking oil. And then they added garlic, they added tea instead of wine. And so just a slightly more culturally appropriate mind diet. And then of course there's like exercise, socialization. There's the good thing is that Tai Chi is something we all would love for our patients anyway. So this is the time to even further encourage it. And there's also other types of traditional Chinese exercises like Qigong and other ones. But I think any of these exercises would be great and also good ways of having socialization as well. Of course, I feel like every patient I talk to does mahjong somewhere if they are still socially active. And then there's also local community centers. Like there's the Sunshine Garden Chinese Senior Community Center, which I think I've referred some patients to in the Seattle area. Um, so those were some of the cultural things I want to talk about. I just wanted to also check in again to see if there's any questions about things I've talked about otherwise. And then I see, thank you. Something that someone's seen in clinic is the video or phone interpreters can be confusing. So slowing things down, yes, explain things in chunks. Yeah, thank you for breaking things down into small bite-sized pieces is very helpful for the interpreter section. Thank you. Yeah, and there are some things that some families and patients have that the interpreter's not interpreting things quickly and cause family stress, so it could be tricky. And the interpreter needs to be counseled that it's okay to stop interpreting if the patient says now or not again. That's all very helpful tidbits and information. And thank you for adding that to that is very, very important and very true. Okay, great. Any other questions otherwise?
Hey, this is Angela. I don't know if you can hear me.
Yeah, I can hear you.
I am not typing, I'm just talking. Hopefully I'm not
Okay.
violating any traffic safety laws. Hey, so yeah, this was so amazing. Like honestly, part of it when you were talking about some of the care and the not wanting to admit symptoms and things, honestly, I thought I was back in Montana. So I think there's some things that are like culturally relevant everywhere.
Yeah, 100%.
And I don't know if that's just me being empathy and like feeling like we're all human and everything. But anyway, yeah, like stubborn Montanans who just don't go to the doctor. it's a different culture, but there's some alignment. Yeah, it's just when I do interpreting in memory clinic, you know, I don't always have time to do this, but if I have some time,
Mhm.
I'll try to start with you know, if it's not one of our beloved, you know, in-person interpreters who just we just love and know well.
Mhm.
If it's the video service, I'll do a little primer at the beginning, like, hey, this is a person with memory loss. You know, it's okay to paraphrase and skip over things if you think they're saying the same thing over and over. And you know, then I'll also say I'm going to ask you at the end if you can let me know if they had if you thought they had any speech issues or
Mm,
word finding issues, if you feel
good point.
comfortable sharing that, because when I'm interviewing a patient, I will notice their speech, you know, issues, and you can kind of get a sense of that even with a patient speaking a foreign language, but I won't necessarily know if they use the wrong word for car or something.
Mm.
And so I'll kind of give them a heads up, like,
Mm.
hey, you're going to get to use your language skills even more today. And like give them that permission to
Mm.
really lean into their interpreting skills. And I think that works well. And then, you know, there are just times, and I think this is when it's more of an off language. Like I'm just thinking, I have a patient from Bulgaria
Mhm.
who her daughter's just like, the Bulgarian interpreters are crap. Just let me do it. And I don't have any other way to know if she's right or not. And she seems to have her mom's best interest at heart. So after the first intake visit, where I got a sense of like this daughter's doing right by her mom, I just let her do it. Because she's just sitting there the whole time shaking her head. No, that's not what she said. Do you know what I mean?
Yeah,
I
no.
think you sometimes have to use your best judgment. Like if they're getting upset over she didn't say car, she said truck, and it's like, oh
Mhm.
my God, okay. Like
Yeah. No, that's a very helpful reminder to know. That's actually really, I really love also the pearls that you talked about, like with the mentioning if they have aphasia or also giving the interpreter permission and like how to contextualize the interpreter visit is super important, super helpful. And I think I've also had similar things where I think nonverbal cues from both the patient and their families are also super important too. I think these are all things I wrote in my notes and I've put them on the slide, but the nonverbal cues are really helpful too. So I thank you for bringing this up because I've also had this similar experiences with certain. There's been one or two interpreters where I'm like, I speak Chinese and I recognize that this was not incorrect. This was incorrect, and I'm so glad that I was able to catch that. So there is nuance here. It's not a one size fits all. So and some interpreters might be better than others, or like you said, our in-person ones are amazing and wonderful. Thank you for bringing that up, and those are all super helpful points. And hopefully you drive safely. I realize I'm getting low on time, and sorry, I want to respect people's time, so I'm going to move on. That was most of the cultural stuff, and then a little bit of interpreting. Otherwise, the last couple points is some caregiving challenges. As I mentioned before, with the filial piety, families often the informal caregiver, and they don't have any training per se. They found like 42% of Asian American families provide care to an older adult compared to 22 the non like Asian population, which is also a big difference. And they provide this care for years also, and unfortunately they lack the professional knowledge and training, so they like run into more challenges and higher levels of burden. And there was a survey that said that some 70% of Asian Americans said that they are worried about having to take care of an aging family member. And what was even more striking was that there is a super high prevalence of suicidal ideation dementia caregivers, 32% compared to 2.7% in US adults in a major study. Um, and I think there's a 2021 Alzheimer's Association report that said that sorry, going back, just obviously then check in with your caregivers. That shows how stressed out they are and how much you're caring for the patient, but also their family is also involved in that care too. So making sure you check in if they see that they're struggling, and that gives even more credence to why you need to discuss in terms like long-term facilities and other things. 2021 Alzheimer's Association report talked about how amongst all ethnic groups, Asian caregivers were least willing to consider a care navigator similar to the patient in the case to guide them through. And only 38% believe that having access to a care navigator would influence their decision when selecting a healthcare provider. But then they express the greatest challenges once again. So there's that discrepancy where, unfortunately, they would really benefit from assistance, maybe long-term care, definitely care navigator, but they're unfortunately the least willing to. I don't think the study commented specifically on, I, like in terms of, I think a lot of it was like they felt that there'd be like bias, in terms of, or like they wouldn't have like the best care, or there'd be some sort of discrimination in some sense, or also they would want to really understand the ethnic background of the person being cared for, and they felt like that they didn't think that the care navigators would be able to do that, unfortunately. So this is still ongoing research on how to support these caregivers, in terms of, there's like a cool like NYU study, looking into how to engage online communities, partner local organizations. It's like they had a whole wraparound service, which is really cool. And they focus on very practical skills. And so I think that's still ongoing study. And there's other ones too. There's some culturally tailored programs to improve caregiving skills. There's actually really good sites online, like caregiver.org is also another one that has very culturally specific things. And so I think there's hopefully room for growth there in counseling as well. And lastly, representation and research. Unfortunately, receive less than 1% of clinical funding, even though they're obviously a large proportion of people with this dementia. And then there's ongoing studies there too, though, to help improve that to be, there's ones, the Asian cohort for Alzheimer's disease and UCSF are doing Asian-specific ones. But unfortunately, there's once again that stigma in terms of 54% don't want to be quote unquote guinea pigs. So there is precedent in history of having, concerns about care. But then ways to that some studies are looking to motivate patients to increase participation is if researchers can speak the language, obviously, and represent their community in research and benefit them. I think intellectual enrichment is always something that these patients are looking for in some way. And there's other helpful studies also to look at improving public health messages to improve early detection. And they modify existing public health messaging and ads with API photos to contact like Alzheimer's Association to get connected with a healthcare provider. So there's ways to kind of, and obviously our UW, there's research at UW as well, which is great. So how to tailor our communications. Once again, like I think I mentioned, we can use positive words to describe brain health, and when designing educational materials, be explicit about memory loss, have very clear, concrete messages, and then hopefulness and concreteness. It should be there in terms of there's something you could do about dementia, so it's not so much about the fatalism. Photos should show happy, authentic relationships. Outreach should be targeted specifically to each Asian culture and make the call to action clear. If it is contacting Alzheimer's Association or connecting with memory, brain wellness clinic or whatnot, just making that super clear. And then just something else to note is that not all adult children have strong or positive relationships with their older loved ones, so just be sensitive to that, especially if the caregiver looks like it's not a thriving situation. And so I think what's important is we continue to educate and advocate for our patients, encourage cognitive evals on our standpoint, but increase our own outreach and engagement. And then, it's important to increase federal and state funding for this research, support the caregivers. There's cultural competency training. Actually, even Ethnomed has some, and they also have like videos on how to do like cultural greetings, like hi, hello, and stuff like that in different languages. And so we could try to do those. And once again, just kind of educate ourselves as much as possible in terms of our patients and their backgrounds. Any other thoughts or experiences? And I think we are out of time, I believe. So, the case, I think it just to kind of, I think a lot of it is just about utilizing hard review interpreters, consider the root us if somebody needs cognitive testing, connect with local resources. A lot of it's just about counseling, just keeping in mind the patient's perspectives of potential fatalism, filial piety, that they might be, want to avoid, are a little superstitious, want to avoid bad juju. But yeah, in the summary. So, large, diverse, growing population, including the Chinese American population with language barriers. We need to improve education of dementia. We need to destigmatize, increase culturally and linguistically appropriate like dementia education, use appropriate cognitive tools, really help the informal caregivers, improve our research studies, and do ongoing public health work. Thank you. I know we're over time.
We're right on time, Clara. You have 5 minutes to spare, so you're
Okay.
doing great. That was fantastic. That was a really awesome presentation. If there are any last questions or comments, feel free to unmute and share those. We have a few minutes left.
Thank you so much for giving this talk. This is Yanni. I just have a question about I feel like a lot of my Asian patients have just not very good impression about being on nursing care or at a SNF in general, and they have a kind of like the sense of being abandoned by family, and that's kind of what I guess experience in my own cultural kind of experience as well. I guess I was just wondering if you have any tips in navigating those conversations, especially for patients who the caregivers are, they're not in a great situation and you see a lot of caregiver burden.
Yeah, I think that's a great question because I think it is really challenging. Um, I think um, I think involving um, I think the name and the local facilities are really important because I think, for example, it's a different level. It's the independent housing in terms of in International District, there's a place called Legacy House, and so I think that's a assisted living facility, I believe. Somebody can correct me if I'm wrong, but then I think having that name and that familiarity with that, I think that I think it starts with using local community resources that they trust. And so places like Legacy House and ICHS and stuff like that are things that I've noticed that my Chinese and Asian patients recognize and appreciate. And so I think this is not answering your question, but the other day I think I referred somebody to ICHS PACE, and I mentioned, oh, it's a system, it's with Legacy House. She's like, oh yeah, Legacy House, and she was very willing to like, oh yeah, I want this referral. And so I think it's harder here because I don't think we have that many nursing homes that speak Asian languages. I'm going somewhere um, in Oakland, California. I actually had interactions with nursing homes that speak Chinese and Cantonese and other Cantonese Mandarin and other languages. And so finding those places would be super helpful to encourage patients to be able to feel like they belong and join there. In places like if they don't have that opportunity or chance, I think then it just comes down to kind of the counseling and maybe the proximity to family and other things that they value. It kind of just goes back to like what matters to them and like what their goal is. And I don't have super helpful advice if there isn't that like cultural component that hopefully is more attractive to them. I don't know if that answered your question. But yeah, I think that's something that I definitely still struggle with for sure as well. And I think it's something that is hard to address until things change where we have more communities that support these type of patients. But we could do as much as we can to counsel and support the patient safety and align with them. And also, maybe, yeah, especially if those caregivers are struggling a lot, that could be another hopefully alignment.
Marissa brought up Kinnon, which has rehab and assisted living and some
That too. Thank you.
community-based resources, as one potential resource to add to the things that you already mentioned.
Okay, thanks
This
so much. Yeah.
This is fantastic, Clara. Thank you so much. We're at time, but you should take some time to read and maybe copy the chat. You're getting a lot of kudos. You've gotten a lot of applause. You really did a fantastic job with this presentation. And thanks so much for sharing all of this with us.
Thanks, Kate. Appreciate it. Thanks, everyone.
Have a great
Thanks
day,
also for everyone's
everyone.
insights too. It's super helpful. Bye, everyone.